أنا حابب أشكر على هذا التنظيم الرائع يعني، وحابب أشكر أستاذ الدكتور أحمد عبد الجليل على الدعوة الكريمة، وأخي العزيز دكتور أحمد زكي ومحمد عبد الباقي، وإن شاء الله موفقين وحاجة رائعة يعني. أسعدتمونا بالتكريم بتاع النهارده في بداية المؤتمر يعني. شكرا ليكم جدا. بشكر الدكتور رمضان على كلامه الكتير عليه بصراحة. ربنا يبارك فيك. Now we are facing a 70 years old male patient who was rushed to the medical room of Aswan University Hospital, complaining from sudden onset of severe chest pain, shortness of breath, and sweating. He was a hypertensive on diuretic medication, no past history of heart or lung disease, history of left knee replacement 4 weeks ago, and limited mobility. General examination, patient was tachypneic, pale, diaphoretic, pulse was 120 beats per minute, regular, equal on both sides, blood pressure 90/60, respiratory rate 32, temperature 37, raised the GBP, edema, erythema, and tenderness over left cuff. Local cardiac examination, apex beat was normal location, and there is a parasternal uplifting heave. There was tachycardia, loud B2, no murmur or pericardial friction rub. Chest auscultation, there was diminished air entry over the base of the left lung. Look, ECG in the ER showing a sinus tachycardia and imagination white side. That means S1Q3T3. And this is suggesting acute RV dilatation. What is your diagnosis? Is it a pulmonary embolism, acute coronary syndrome, aortic dissection, or pericarditis? My diagnosis exactly is a pulmonary embolism. Why the diagnosis is a pulmonary embolism? Because according to the ECC guidelines 2019, divided the predisposing factor for venous thromboembolism into strong risk factors and moderate risk factors and weak risk factors. One of the strong risk factors in our case is a knee replacement. So there is a high possibility for a pulmonary embolism. Also, when we suspecting a pulmonary embolism, we should assess the clinical probability for pulmonary embolism according to the revised Geneva scores, that including previous pulmonary embolism or DVT, and it will take a 0.1. The heart rate 75 to 94, it will take a 0.1. But if the heart rate is more than 95, it will 2 points. Surgery or fraction within the past months, hemoptysis, active cancer, unilateral limb pain, unilateral swelling, age more than 65 years, each one will take a 0.1. If the score is 0 to 1, this is a low probability for pulmonary embolism. If the score is 2 to 4, there is intermediate probability for pulmonary embolism. If the score is more than 5 or equal, it is high probability for pulmonary embolism. And in our case, the score was 6, so there is a high probability for pulmonary embolism. Also, according to the pulmonary embolism rule-out criteria, that include 8 clinical parameters: age less than 50, heart rate less than 100, saturation more than 94, and 5 no. No unilateral leg swelling, no hemoptysis, no surgery or trauma within 4 weeks, no history of DVT, no estrogen use. If the score is 0, the probability for pulmonary embolism is less than 1%. But in our case, there is the score 4. So the probability of pulmonary embolism cannot be excluded according to this score. In spite of all the previous data, the diagnosis of pulmonary embolism is still challenging case because 40% of patients with pulmonary embolism, no predisposing factor are found, and 40% of patients have normal oxygen saturations, and 40% of patients, the only abnormality may be sinus tachycardia. So we need confirmation of diagnosis by another modalities, and the further modalities depend on hemodynamic stability. What is mean with hemodynamic stability? Hemodynamic stability means cardiac arrest or hypotension. Hypotension may be obstructive shock or persistent hypotension. Obstructive shock means systolic blood pressure less than 90 millimercury and the need for vasopressor in spite of adequate filling state. And there is end-organ hyperfusion. Persistent hypotension means systolic blood pressure less than 90 millimercury or drop of systolic blood pressure more than 40 millimercury and lasting for 15 minutes in spite of absence of arrhythmia, hypovolemia, or sepsis. This is a diagnostic algorithm for suspected pulmonary embolism without hemodynamic instability. It depends on clinical probability. If the high clinical probability, we should order a CT pulmonary angiography. If the CT pulmonary angiography is positive, confirm diagnosis. If negative, exclude pulmonary embolism. But if the clinical probability is low or intermediate, we should do D-dimer. If the D-dimer is negative, this excludes the pulmonary embolism because the D-dimer is a good negative test. But if the D-dimer is positive, we order a CT pulmonary angiography because the D-dimer is not specific for pulmonary embolism. This recent years scores that combine three clinical parameters with the concentration of the D-dimer, not a positive and a negative. And this consists of three clinical parameters: clinical sign of DVT, hemoptysis, pulmonary embolism, most likely diagnosis. If the score is 0, D-dimer concentration less than 1,000, pulmonary embolism is excluded. If the D-dimer is more 1,000, the pulmonary embolism is highly suspected, and we should order a CT pulmonary angiography. Also, if there is one or more items from the items of the clinical of the year's scores, we should recommend the D-dimer. If the D-dimer is less than 500, we should order a CT pulmonary angiography. If the D-dimer is more than 500, we suspecting pulmonary embolism, and we should order a CT pulmonary angiography. According to the year's score, CT pulmonary angiography was avoided in 48% of the included patients, compared to 34% if the Wills score and the fixed D-dimer 500 have been applied. But if we have a pulmonary embolism with hemodynamic instability, a suspected pulmonary embolism with hemodynamic instability, there is no time for investigation. We should do bedside transthoracic echo. If there is RV dysfunction, we should recommend the CT pulmonary angiography if immediately available. If not available, we should start treatment with pulmonary embolism. What are signs that can we see in patients with suspected pulmonary embolism? We can see by transthoracic the dilated RV and the McConnell signs. McConnell signs, it means there is hypokinesia of the RV free wall and the sparing of the apex. And this has a sensitivity and specificity of 94% for pulmonary embolism. Also, we can see 60 over 6 times. This means the pulmonary acceleration time is less than 60, and the pulmonary arterial hypertension is less than 60. Also, we can see right atrial thrombus or right pulmonary artery thrombus. What is the management? The management depends on, firstly, on risk stratification of the patient. We should risk stratify the patients, and the patient can be classified into high-risk pulmonary embolism or intermediate high, intermediate low, or low pulmonary embolism, low-risk pulmonary embolism. High pulmonary embolism depends on 4 clinical parameters: hemodynamic instability, pulmonary embolism severity index, RV dysfunction, and elevated cardiac troponin. If the 4 items is positive, pulmonary embolism is a high risk. If the patient is hemodynamically stable and the other data is positive, the patient is intermediate high. If the patient is hemodynamically stable and there is pulmonary embolism severity index positive and +1 or plus RV dysfunction or elevated cardiac troponin, it is intermediate low. Low, the 4 parameter is negative. It is considered low risk. What is the pulmonary embolism severity index? It is consists of the following clinical parameters: age, cancer, chronic heart failure, chronic pulmonary disease, heart rate more than 110, systolic blood pressure less than 100, and saturation less than 90%. This is simplified form of pulmonary embolism severity index. Each one will take a 1 point. If the score is 0, this means 30 days mortality risk is 1%. And if the score is more than 1 point, the risk of mortality, 30-day mortality risk is 11%. Once you suspecting pulmonary embolism, you should start the treatment. There is no delay. Once you suspecting, you should start anticoagulations. If patient is hemodynamically stable, it is considered a high-risk patient, and we should hospitalize the patient, start reperfusion therapy, and the hemodynamic support. If the patient is intermediate risk, we should hospitalize the patient, start anticoagulation parenteral, and monitor the patient, consider risk or reperfusion if duration occurs. If the patient is low risk, we can discharge the patient to the home and start anticoagulation at home. This is safe. Before you start reperfusion therapy, whether either TPA or streptokinase, you should ask about the contraindication for thrombolytic therapy. Which types of anticoagulation you can give? There is 2 types of anticoagulations, parenteral anticoagulation and the oral anticoagulation. Parenteral anticoagulation should be started if there is high or intermediate probability of pulmonary embolism without delay. And low molecular weight heparin or fondaparinux is recommended over unfractionated heparin. When you start oral anticoagulations, NOAC is recommended in preference to vitamin K antagonists. But NOAC are not recommended in patients with severe renal impairment during pregnancy, lactation, and in patients with antiphospholipid syndrome. Rescue thrombolytic therapy is recommended for patients with hemodynamic deterioration on anticoagulation treatment. Alternative to rescue thrombolytic therapy, surgical embolectomy, or percutaneous catheter-directed treatment should be considered for patients with hemodynamic deterioration and anticoagulation. Routine use of systemic thrombolysis is not recommended in patients with intermediate or low-risk pulmonary embolism. Duration of anticoagulation. For how long you can give the anticoagulation for patients with pulmonary embolism? Standard duration or extended duration? Standard duration means 3 months and stop anticoagulation. And this is safe in patients with major transient risk factor for pulmonary embolism. But extended durations, indefinite durations, indicated in patients with antiphospholipid syndrome, no identifiable risk factors, or persistent risk factors such as active cancer, autoimmune disease, or inflammatory bowel disease. Or there is a minor transient risk factors for pulmonary embolism. What is mean with major transient risk factors and the minor transient risk factors? The major transient risk factors, it means the risk of recurrence for pulmonary embolism is less than 3% per year, such as surgery with general anesthesia for 30 minutes, hospitalization for more than 3 days due to acute illness, or trauma with fracture. Minor transient, it means the risk of recurrence of pulmonary embolism is 3 to 8% per year. And examples for this is minor surgery with general anesthesia for less than 30 minutes, admission to the hospital for less than 3 days with acute illness, estrogen therapy, pregnancy or puerperium, or bedridden but outside of the hospital for more than 3 days. All this considered a minor transient risk factor. If extended oral anticoagulant is decided after pulmonary embolism, reduce the dose of NOAC, such as apixaban or rivaroxaban, apixaban 2.5 milligram BID, or apixaban 10 milligram once daily, should be considered. In patients who refuse to take or unable to tolerate any form of anticoagulant, aspirin may be considered for extended duration. But aspirin reduce recurrence of pulmonary embolism by 30% only. But oral anticoagulant reduce the risk of recurrence of pulmonary embolism by 90%. It is a great difference. Thank you.